Did you know that having obesity or excess weight is a major risk factor for heart disease? We're speaking with cardiologist Dr. Subodh Verma about the connection between obesity, heart health, and the role of medications. Before we get started, let me know in the comments where you're watching from and tell me if it's your first time joining us. Dr. Verma, thank you so much for being here with us.
It's my pleasure.
So how has your understanding of obesity as a driver of heart disease evolved over the course of your career?
Overweight and obesity, first and foremost, are chronic conditions, right? And my understanding of the field and the field in general, both scientifically and personally, has changed markedly. Overweight and obesity have often been, complications that we haven't actually had good treatments for. And, in the absence of being able to provide therapies for people living with overweight and obesity, it has been exceedingly difficult to have a conversation around, modifying overweight and obesity as a chronic disease. So the first lesson that I think we've learned is that overweight and obesity are not always the patient's problem. It's not always, please exercise more and eat less, and that's the recipe for weight loss. We know that those solutions don't work, and we know that what drives overweight and obesity is multifactorial. It's a balance between, intake and metabolism, and intake and metabolism are not always, necessarily in the hands of patients. And helping people understand that they're not alone and understanding their perspectives around what drives that imbalance between intake and output has been a real a significant shift in our understanding over the last several years. It's understanding what drives sustained weight gain and what are the underlying determinants of it have allowed doctors to actually forge that meaningful relationship with patients, understand their perspective, and tailor both pharmacological and non-pharmacological strategies to best suit their needs. And finally, I would say that we're living in great times now where we have access to some of the most profound therapies to treat weight and associated cardiometabolic risk, and that's the GLP-1 receptor agonist family. And there's many of these agents, and I'm sure we'll talk about them, but they have provided us with complementary, durable, formidable tools in our real war against cardiometabolic disease.
We're going to pause here and do our trivia question. If you put a guess in the comments to this question, you'll receive a collection of heart-healthy 10-minute meal recipes for free. These are great suggestions for easy, healthy meals, and all you have to do is answer our question, which is, true or false, cardiologists are physicians who specialize in treating heart conditions. Is that true or false? Are cardiologists physicians who specialize in treating heart conditions? Put your best guess in the comments, and you'll get that guide delivered to your Facebook Messenger inbox for free. And folks, if you can think of any friends or family members who might find this show helpful, please tag them in the comments so they can tune in too. It must be an exciting time in medicine to suddenly have these tools that work. You alluded to this earlier. For many people, diet and exercise alone doesn't help them reach a healthier weight. And suddenly you as a physician have these medications in your armamentarium that can really help people be successful in a way that is going to reduce their cardiovascular risk. How have you seen your field of cardiology adapt and change because of the availability of these tools?
Oh, it's a new day. It's a new day for patients. It's a new day for physicians. It's a new day for the healthcare system. Overweight and obesity is linked to so many cardiometabolic and chronic diseases, and we need solutions that are effective, durable, formidable, are relatively well tolerated, and are associated with cardiovascular risk reduction if we're going to win the war against cardiometabolic disease. And the GLP-1 receptor agonists have really been a foundational pillar in that regard. As I often say to my patients and my trainees, I've waited a long time for this. And the patients have waited a long time for these strategies because diet and exercise are important, they're complementary, and they need to be continued. It's not a competition between diet, exercise, and medication. These are all on the same team, and we're all working together in a patient to achieve the best outcomes. But the cardiology field has been greatly influenced by this class of agents across several lines of evidence.
So we know a lot of people don't want to be on these medications long term. When we stop taking the medication, do we lose the cardiovascular benefit as well?
Like all pharmacological therapies, people need to understand that these are chronic diseases and they need chronic disease management. People who take an aspirin a day after a heart attack, or they take, a statin such as, rosuvastatin or atorvastatin after, if they have cardiovascular disease or high cholesterol, we know that those medications have to be taken every day. And if you stop taking them, the cholesterol levels rise. If you stop taking your blood pressure medications, the blood pressure rises. If you stop taking them, the weight comes back at the end of 1 year, 2/3 of the weight is regained. Now, there aren't any studies that have shown whether cardiovascular risk, returns back to normal or returns back to baseline. But I would assume that if you don't take the medications, that the overall cardiovascular benefits would actually be diminished.
So, what are the primary mechanisms in the body linking obesity to heart disease, and how do these medications target those mechanisms?
The central mechanism through which adiposity or visceral adiposity leads to cardiovascular disease really relates to the production of inflammatory cytokines, also called adipokines, from the visceral fat. Visceral fat is a reservoir for these adipocytokines, which are pro-inflammatory molecules released into the circulation that can have local effects, but can also have sort of distant and systemic effects throughout the body. They can affect blood vessels, they can affect the heart, they can affect the brain, and they can affect all sorts of other organs, leading to what we call pro-inflammatory milieu that leads to cardiovascular disease. In addition, we do know that medications such as GLP-1 receptor agonists, they afford cardiovascular protection through a variety of mechanisms. They interact with centers in the brain that actually, promote satiety. They interact with blood vessels. They interact with the liver. They interact with the muscle. And they really change metabolism. They change overall, weight. They have effects to limit, NT-proBNP, which is secreted from the heart, which is probably an important mechanism through which these drugs are effective in heart failure. So there's a large number of mechanisms through which overweight and obesity lead to cardiovascular disease, and there is a sort of multifaceted mechanisms through which GLP-1 receptor agonists really overcome this cardiovascular risk.
So, an endocrinologist told us recently that when it comes to fat tissue, it's all about location, location, location. Does losing belly fat specifically help reduce our risk of heart disease more than just losing weight in general?
Visceral fat or belly fat is a really important component of cardiovascular risk. And, location matters for sure, 100%. Belly fat is pro-inflammatory, pro-atherosclerotic, and data suggest that visceral adiposity or waist circumference is a very important determinant of future cardiovascular risk. In fact, many of us have advocated for waist circumference to be the new vital sign. When someone comes to me as a patient, our usual vital signs are what's your heart rate, what's your respiratory rate, what's your blood pressure, what's your temperature. And why not add a fifth one? What's your waist circumference? Because that really tells us about cardiometabolic risk and cardiometabolic risk factors. Because as you can imagine, you can have someone who has a BMI of 25, but has a increased waist circumference. And there are many ethnic groups where BMIs may not necessarily capture the distribution of fat. And you may have someone with an increased waist circumference who otherwise overall has a BMI that is still below 27 or below 25 and may not necessarily fit criteria for a certain clinical trial, but it doesn't mean that their so-called metabolic risk is not high. So I think about belly fat as metabolic risk, and therefore those are patients who are at high risk of developing diabetes, high risk of developing cardiovascular disease, high risk of developing fatty liver disease, high risk of developing heart failure, and high risk of other chronic diseases.
In case you're just joining us, we're here with cardiologist Dr. Subodh Verma, talking about the connection between obesity and heart health and the role that medications can play. We're giving away a collection of heart-healthy 10-minute meal recipes if you answer our trivia question, which is, true or false, cardiologists are physicians who specialize in treating heart conditions. Is that true or false? Are cardiologists physicians who specialize in treating heart conditions? Put your best guess in the comments, and you'll get that guide delivered to your Facebook Messenger inbox for free. Folks, we do this show every month, and we want to make sure you never miss an episode. Be sure to like and follow us on Facebook and YouTube to stay up to date. So are there certain groups of patients based on ethnicity, gender, or comorbidities who benefit more from obesity medications in terms of heart disease prevention?
The answer to that is no. I think the benefits are seen across regions in the world. They're seen across males and females, across different ethnic groups, so the benefits are consistent. There doesn't seem to be a certain group that is less or more likely to derive cardiovascular benefit. There are some differences between males and females with respect to weight reduction with these agents. We know that females lose more weight with GLP-1 receptor agonists compared to males. The mechanism of that remains unclear. People living with diabetes tend to lose less weight than people without diabetes on these agents. And the mechanisms for that also remain unclear. So those are the two sort of groups where there are some differences in weight. However, there are no differences in males or females or people with or without diabetes as it relates to their cardiovascular benefit. And I just want to underscore that point because weight reduction with these agents is important, but weight reduction with these agents is not believed to be the dominant mechanism through which cardiovascular benefit is seen. And I think it's hard for people to, sometimes get their head around that, to say, can you have someone who loses only 5% of their body weight but still get a 20% reduction in major adverse cardiovascular events? And someone loses 20% of their body weight and also get a 20% reduction in their cardiovascular events. The degree of weight loss seems to be unrelated in some of these clinical trials to the degree of cardiovascular protection.
I'm so glad you're saying this because one of the things that I feel like I'm constantly hearing from physicians is, even losing 5 to 10% of your body weight has such big implications on heart health. And then I love hearing you say that these medications have additional benefits kind of beyond how the number on the scale changes. When you're thinking about these agents for your patients, you're really focused on what's happening with their cardiac markers, not necessarily how the number on the scale changes.
100%. I prescribe these agents for cardiovascular protection. These are vascular drugs. They're disease-modifying drugs. And in addition to that, they offer benefits for weight reduction and benefits on A1C control. And I think, everybody, we look at this sort of holistically, right, from a patient's perspective. But having this conversation with someone we've operated on, having this conversation with someone who's had a heart attack to say, I'm prescribing you this medication because we believe these are metabolic modulators. We believe they're vascular protective, and they're going to target, cardiometabolic risk, heart risk and metabolic risk. And by reducing heart risk and metabolic risk, you will also observe that you will have a reduction in weight and sugar. And these are all of the key facets of the cardiometabolic syndrome: heart disease, liver disease, kidney disease, high sugar, high weight. It's one solution for a multifaceted problem that is of growing proportions.
So, if someone watching at home is wondering, is this a conversation I should be having with my physician? How might you encourage them to think about, how to start that conversation and whether they might be right for these medications?
Speaking to your doctor is a good thing always about things that are on your mind. And, if weight and cardiometabolic risk is on your mind, having a conversation with your physician or nurse practitioner or whoever you're working with, healthcare provider, to say, I've learned about the overall metabolic and cardiometabolic benefits of GLP-1 receptor agonists. Do you think I'm the right patient for it? And, I think that would be one way of starting the conversation. Particularly, for people with diabetes, it's well recognized that these are, important strategies for metabolic control and weight control. For people living with overweight or obesity, knowing that these are treatments not just for overweight or obesity, but for cardiometabolic risk reduction, and having that emphasis with your physician or nurse practitioner, I think, is quite valuable.
What would you say to someone who feels like medication is the easy way out, that we shouldn't be promoting medication use over lifestyle interventions?
So I would say it's not a competition. These are complementary strategies. We're all on the same team. And diet and exercise and not smoking and watching your saturated fat intake and watching your caloric intake and watching your alcohol consumption and good sleep habits, managing stress. These are all important and really critical components of any discussion that a doctor has with their patient. And they need to be the foundation upon which we build, pharmacotherapy. Remember that pharmacotherapy and medications have been tested in clinical trials on top of and in addition to all of these lifestyle modifications. In fact, many of the clinical trials require dietitian support in both groups so that we can answer the question whether lifestyle modification was important and whether the benefits were seen in addition to lifestyle modification. So these are therapies that are beneficial on top of background therapy, background, lifestyle, and should be part of a holistic sort of strategy long-term to improve outcomes. Now, as you said, many people feel that, they should have the power within themselves to take charge of their problems. But they should be reminded that the benefits of these therapies are not simply to further add to what they're doing in terms of weight, but to further add vascular benefit that they may not be able to get simply through weight reduction.
So, for someone who's feeling a little unsure about talking to their doctor about exploring treatment, how do you explain the cardiovascular risks of untreated obesity and the potential benefits of starting now to manage it?
Overweight and obesity really carry a lifetime cumulative risk. And it's not just, how much visceral adiposity, but it's for how long have you carried that excess risk. It's like any other risk, right? If someone has a smoking history, it's not if you've smoked one cigarette for 1 week. It's have you smoked one pack of cigarettes for 10 years. So cumulative risk is what we see. And remember, overweight, obesity is no different than any other risk factor. The more you have it and the longer you have it, the higher is your risk of cardiovascular and cardiometabolic disease. And that extends to risk of heart attack, stroke, peripheral arterial disease, as well as heart failure. The sooner you start, the better it is. There is no, you're never too early and you're never too late. And that's the message to patients. We want to empower them to know that no matter where you are in your journey with overweight, obesity, and cardiovascular and cardiometabolic risk, there is an opportunity to intervene and there is an opportunity to reduce risk. The sooner you do it, the better are the outcomes, and there's scientific evidence to back that up.
So, no matter where we are, now is the right time, is what I hear you saying.
That is right.
Dr. Verma, thank you so much for joining us tonight. This has been an amazing conversation.
It's my pleasure. Thank you.
And a big thank you to everyone watching at home. We so appreciate you being here and chatting with us in the comments. Before we go, here's the answer to our trivia question. True or false, cardiologists are physicians who specialize in treating heart conditions? The answer is true. If you didn't get to answer the trivia question, but you'd still like those heart-healthy meals, just leave a comment for us and tell us what you thought of the show. We will be back to you with a new episode in a few weeks. Until then, please stay safe and take good care. Good night.